part of the student advisory group that helps run the speaker series. And today we're going to have Swarnima Chaudhry speaking on mental health treatment for emergency responders and the ethical issues that come with that.
Thank you, Alan. Hello, everyone. Thank you so much for coming during your Monday lunch hour to have what will hopefully be an interesting conversation about emergency responders, mental health, and ethical considerations that go with it. So my name is Swarnima Chaudhry, as Alan said, and I am a research assistant at the National Mental Health Innovation Center, which is right across the parking lot in the CU Medicine building. And I also interned with Responder Strong, which is a grassroots organization that brings together emergency responders from fire, EMS, law enforcement, dispatch, emergency department to bring mental health supports to emergency responders in a better way. Finally, I am a Master of Public Health student here at our very own Colorado School of Public Health, and I'll be graduating in the fall. So, in our agenda today, I'd like to do a quick intro to the two organizations that I just mentioned. We'll talk about the current state of mental health in emergency responders nationwide and a little bit in Colorado. We'll talk about stress injuries, and we'll get to that, and I'll tell you what it's all about when we get there. Ethical considerations, and finally, I'll wrap up with some parting thoughts. Some housekeeping things. I know everyone's eating. I hope you enjoy your lunch. Feel free to move around. And then lastly, I'd like to just declare this a safe space. So I'd like you to be present in the safe space with me for the next 45 minutes or so. Does that sound like a good plan to everyone? Yeah? All right, perfect. So let's start with National Mental Health Innovation Center. I'm going to call it NMHIC because it's a bit of a mouthful. And NMHIC's goal and mission is to find and scale innovative approaches to address current gaps in the mental health care system. So one of the ways that we do it is by harnessing virtual reality technologies. So for example, we partner with Anchorage Department of Corrections to bring virtual reality headsets to the incarcerated individuals where they can do guided meditation. Preliminary results have been quite positive. They say it brings them a sense of like being outside of jail, and it helped with their mental health outlooks. We also integrate mental health literacy and resilience information into upstream coursework. So, you know, in places like business schools or schools of education, maybe trauma and mental health isn't focused on. So our goal is to bring mental health literacy to those areas to get it into the new workforce. And then finally, collaborating across sectors. So there's this tendency that I've noticed, and I'm sure many of you have noticed, where we silo within ourselves, we're not talking across sectors. NMHIC's goal is to break that. Responder Strong has similar visions, just a different take. Responder Strong is partnering with NMHIC and is housed with us, with NMHIC. And its goal is to create an accessible network of existing resources, use the people that have expertise with emergency responders, leverage all of it to bring better mental health supports to address the unmet needs of emergency responders. They've done this so far by creating a crisis text line partnership with crisis text line called, and you text badge to 741-741 if you're struggling. We've initiated inventory on the existing resources that are already out there so that we don't have to reinvent the wheel. And then educating, again, the new workforce. So in Colorado, half of our emergency responders are trained at community colleges. So why not go there and be like, hey guys, mental wellness and resiliency, let's talk about it. So as you can see that NMHIC and Responder Strong's missions kind of come together. That was a great partnership, and I'm kind of born of both. So why should you care about this during your lunch hour? I always like to throw this in because I don't want to be sitting for an hour when I don't have any stake in it. But I would say that emergency responders are human beings, and we're in the healthcare professional, many of us are, and we're charged with caring for them. So that's a good why, I would think. The current state of mental health among emergency responders is a public health issue, and I'd like to come out and say that, and we have to address it. Emergency responders have a distinct culture, and everyone has probably heard of cultural humility, cultural competency. Those are buzzwords, but they hold merit. So when you can understand culture, you can understand context, which helps us be better providers. And then lastly, many of you will come across these issues. Maybe you'll have patients, maybe you are an emergency responder, and you'll come across some of these issues in your arc of your profession. Hopefully I've sold you on that. Let's move on to the current state of mental health in emergency responders. So also, I'm doing the turning thing. If I get dizzy, I might like stand right there and make eye contact with you guys there. So I'd like to start off by talking about condensed exposure. What is that? We'll start with talking about the 1973 EMS Act that Congress passed. The purpose of it was to address the growing need for regulated and standardized emergency services. Before it, you have a rise of non-communicable diseases that was turning into an issue, and then accidents and injury rates were going up around that time too. So Congress was like, we gotta do something about this, so they passed it. It was great to streamline our infrastructure, bringing in EMS, fire together, but what it also did was created this entire culture and field where you have people going day in, day out, and finding those exposures, going into those situations without getting time to reset and integrate those traumatic things or things that they might have seen. So, occupational exposures. Anticipated and accepted exposures that when EMS, the whole field of emergency responders came around, it was like, yes, you're gonna deal with smoke inhalation. Yes, there might be a chance that a needle stick will go bad and you'll have to worry about bloodborne pathogens. There's gonna be back injuries, you're gonna see violence, maybe disasters. All of these are accepted things that people talk about, and there are protocols in place on how to take care of these things in case they happen. But the silent and stigmatized exposures that rarely get discussed, they don't get discussed with students at community colleges, are the things that I've set up there. Unrelenting stress, traumatic images from calls that you might have heard or gone to, interacting with grieving families. Exhaustion, not just exhaustion from the back-to-back calls that you're getting, but the tedium of waiting for a call, like for the 12-hour shift or 10-hour shift that you might have. Where there are humans, there's going to be politics. Department politics are a thing. That can be also hard to navigate. Family pressure of having long shifts, not being able to communicate with your family members because of not wanting to hurt them or expose them. And then finally, ongoing threats to personal safety. My partner, she is a police officer, and I asked her for permission to talk about her today, but she says that she has 12-hour long shifts as a police officer, and that doesn't give her enough time to come back home, decompress, before she has to go to sleep and then wake up at 4 in the morning again to start all over again. Doesn't give her time to integrate. And she also talked about the fact that when she goes in every day to work, even if it, even if she is at a university police department, there is going to be a threat to personal safety or the chance that it could happen, and that takes a toll. So all of these things take a toll. So let's look at numbers that reflect that. So emergency responders have vicarious trauma, and they have daily chronic exposures. And some of these numbers reflect that. In the past year, in 2018, 159 law enforcement officers died by suicide, compared to 148 officers that died in line of duty deaths. For fire in 2017, that's the data, that's the latest data, 103 died by suicide, whereas 93 died by line of duty deaths. Essentially, emergency responders with these numbers are dying by their own hands more so than line of duty deaths. That's saying something. Let's talk about suicide rates versus in emergency responders versus general population. As you can see here, suicide rates are higher for police officers and firefighters than they are for the general population. 13 out of 100,000 for general, whereas 18 or 11 to 17 for emergency responders. Same with mental health outcomes. There are higher rates of PTSD, depression, thoughts of suicide, suicidal ideation, contemplation within firefighters, police officers, compared to the general population. Also have reference slides at the end if you'd like to check out where I'm getting all this information. More than happy to provide that. So in a survey that was sent out in 2015 to about 4,022 people responded, emergency responders responded. They said that out of them, 37% said that they had thought about suicide, compared to 3.7% in the general population. Similar trend in suicide attempts. 6.6% of the respondents said that they had attempted suicide versus the 0.05 or 0.5 that CDC reported as a national average. Those bars are quite striking. Finally, in this case, sleep deprivation is a huge thing. 80%, and this was responses and data gathered from Crew Care app, which is to bring data together and information for emergency responders to help them out. It was out of 1,843 respondents, 80% said that they slept 7 hours or less, compared to 35% of the general population. That's a whole lot of sleep deprivation. I'm running on like 4 hours of sleep right now, and I don't know how people can do it day in and day out. Substance abuse. I would like to point out that substance abuse, a lot of times, it's a symptom. It's not a personality flaw. It's a symptom of the systemic issues going on within our emergency responder cultures. So 36% of police officers in a study for University of Arizona said that within 4 years they were drinking to cope, and so alcohol problems. 25% said that it's part of the working culture. That's how it is to be part of a team. You go out for a drink. And then 25% of police officers said that they were negatively affected by a coworker's drinking. Kind of story with firefighters. About close to 30%, 29% engage in alcohol use, and 10% of firefighters might be currently using drugs. Again, symptom of a problem. EMTs are also particularly at risk. They, about 40%, and a lot of these are probably underreported, are engaging in high-risk alcohol and drug use. More than 20% have PTSD. As you can see, there's not a lot of info that I at least could find on dispatch. So here's a wink wink and a nudge nudge if anyone wants to do some research, because there is a paucity of data. And I know, at least from my public health training, that data drives good interventions, or good data does. So there's areas for improvement. So with these numbers, you can see that there's a problem. Now, there is a drive now in the conversation to change talking about mental health when it's in the very last stages. Now we're going to talk about stress injuries, because that's part of the conversation that I want to be having with all of you, is how do we go from looking at mental illness as this big bad thing to looking at it as something that can be fixed or that can be changed. So stress injuries were operationalized by the US military. they're really good about getting on top of a lot of things. And they say that it's physical injuries that result from living and working in hypervigilant states. Stress injuries are the effects of occupational exposure to wear and tear. So allostatic load, when you're constantly having cortisol running through your system, everything's elevated, that affects things at a cellular level. So your emergency responders are having constant stress on their bodies, which can a lot of other health issues, not just mental health, depression, anxiety, but things like cardiac disease, things like central adiposity, weight gain, fractures that don't really have a reason for being in your back when you're stress injuries can be caused by traumatic calls and sleep deprivation. So what are some characteristics of stress injuries? Stress injuries occur on a continuum. So PTSD, which many of you know about, post-traumatic stress disorder, I'd like to offer that that is a very late stage vital sign. That's like when you're in the red, you're not doing great. Things don't happen in vacuum. Things take time to build up. And though that area is what we want to call stress injury formation. Like I just said, they have early and late changing vital signs. They're physical injuries, which means that there's good news. They can be supported. So if you have parity between the physical health and the mental health, when you're treating them the same, there is hope. Stress injuries have more than one cause. They're dynamic, like I said, and they occur more often when you're already in a state of stress. Think about right now, if you know any emergency responders or are one, you're already ready to go when you're already hypervigilant. It doesn't take much for that to bend and break, you know. So when you're in a better position to deal with things and room for complexity, you're more likely to be able to fix those stress injuries, but not so much if you're already stressed out. So this is the stress continuum model. This is what USMC put forth in their combat and operational stress aid. And it starts with, you know, you're ready to go, you're mission ready, everything's green, you're good at communicating to your supervisors, you're working out, you have friends, you're going to talk to them. Those are signs of a green human being or a green soldier. And then go further along the continuum, and that's when you start seeing things like changes from normal behavior. People, you know, lack of motivation, lack of wanting to be at work, lack of engagement. And finally, you go from injured to ill. So this is the military version. This is what was tried to make it more responder friendly. So we start with the ready, again, sense of mission, you're good to go. You want to go out there and get as many calls as possible. You have room for complexity, which means you have space to examine the traumatic call that might have happened, et cetera, talk it out, get help if you need to in these things. I'd like to say that it is a continuum, so people can go back and forth between these. So someone could have had a very reacting day, but they can make green choices later on, like getting some sleep, and they can go back to that ready phase. The ill, where most people see things happening, that's where it's too late, or it needs a lot more help to bring the emergency responder back into the land of the living. So this is where the conversation needs to change, that let's not let it get to the ill point. Let's start taking actions so that we can mitigate these injuries in real time by starting with talking about mental health, mental wellness, and not just illness. So with all of that, that's stress injuries. So let's go into talking about some ethical considerations. There's I've done ride-alongs, I've done sit-alongs with dispatch. I interned with Responder Strong, so I got to meet a lot of awesome folks and interviewed them and just listened to their stories. And there were a lot of themes that came through what people think about. So these are some things I'm going to leave with you guys to ponder in terms of the ethical considerations. And then I have some, I guess, anecdotes on how some emergency responders would like some of these situations addressed if they were going to go seeking help. So confidentiality is a huge one. HIPAA standards is great, but it's not enough when you're an emergency responder. Can anyone think, I have a quick question for everyone. Can anyone think of something that's different between military folks and then emergency responders in terms of how confidentiality might affect their lives? Yes.
The emergency responders go home to their families, whereas military are presumably elsewhere when they're responding, and they get to go back to their base and discuss things with other people who've just been through what they've been through.
That's a real good point. Would you like a Responder Strong stress ball? Have at it. May your stresses leave. That's a very good point. Yes. Anybody else? Yes, sir.
The military isn't bounded by HIPAA laws, so they probably have more leeway to discuss what happens to them while they're on scene or when they're responding.
Right. So those are two great points. And then the other thing that I'd want to point out, along with what you just said, is emergency responders, they're embedded in the community. So they have to go back and see the people that they just did calls with. So when they're in a mental health crisis, where do they go when they don't want to be seen by the people that they work with every day? You know, where is that confidentiality going to kick in? So it's important to, as a provider, to remember that simple confidentiality for a lay person might not be enough for those that are emergency responders. Other things about confidential. If anyone else thinks of anything, just raise. I'll bring a stress ball to you. Going on to clinician and provider cultural competency. So again, cultural competency, big buzzword, but it matters. I interviewed Carrie A. Friedman, who is a police chaplain and a consultant with the FBI National Academy for their behavioral science unit. Awesome guy. And he gave me this anecdote of, you know, emergency responders see some horrific things. They see some intense things. And one of the things that keeps them from speaking up, and these are from stories that I've heard, I'm not generalizing as to everyone, but from the culture that they're embedded in, talking about those things are hard enough as it is. And they don't want to burden other folks with those traumatic stories. So when they actually go to seek help, if they sit down and they're sharing a story, and then the clinician, that's gonna make the emergency responder kind of go, okay, I want to back up, because obviously this clinician, this is too much for the clinician. And the emergency responder is sitting there going, I don't want to hurt anybody else, you know, like, I know how painful it is, and if the clinician can't handle it, and it's a crying clinician, then it's going to force them back into not getting help. So that's an ethical consideration, is if you're a clinician or a provider, when you see somebody come in that is an emergency responder, do you take the time to say, am I culturally competent? Do I think I can handle it? And if not, then do I refer to someone? So that's just something to think about. What do you do as a provider? Or what do you do as an emergency responder? If you have not that many clinicians in the area to go to, do you stick with the person that, you know, might not be the best fit? What do you do? Gratitude and free gifts. I thought this was interesting because I would have never really thought about it. But a lot of people like to express their gratitude to the emergency responders by giving them free things. While that's a lovely sentiment, it can create a slippery slope. Anecdote from Rhonda Kelly, my mentor and founder of Responder Strong. She said that, you know, there were instances where people go into diners, to law enforcement officers, firefighters, etc. And the owner might offer them free food, free coffee, which is great. But one time, this was a story, that the law enforcement folks would go and get free coffee, and then the owner got robbed one day. And then the owner wasn't too happy the next day. And then when the law enforcement officers came back in, he was very upset and resentful of them because they had failed to stop that robbery. I don't know if you guys can see the issue, but when you're embedded in the community and you might see this restaurant owner every day, and now you have this resentful, weird feeling going on, that makes you less effective at your job. Because you are, you know, emergency responders are community folks. They're there to help community. So free gifts, not the best idea. What Rhonda and other responders have told me that they would like to hear, if someone does want to thank them, is to go up to them and say, "You have a really hard job. I hope you're taking care of yourself. Thank you." And go on from there. That you validated the person, you said thank you, and you haven't crossed any ethical boundaries. So that's something to take away from today. All right. Advice giving, again, not the best. It doesn't quite work, especially with emergency responders, because many of them are strong go-getters. And yes, they might be vulnerable if they're coming to you during a time of mental health crisis, but asking questions, giving them autonomy to figure out what it is that they want to do, that's a ethically more sound way of going about it. When in doubt, ask, and when in doubt, refer. So what I mean by that is many folks are scared of asking the question, are you thinking about suicide? Many people think that, oh, that might put me in liability, that might force them to actually go and commit suicide. That's not the case. Studies have shown that that's not the case. Just literature has shown that that's not the case. Crisis text, and I saw your squinting, so I'll ask you later on about it. But crisis text line folks, they're taught to, yes, go ahead and ask, are you feeling suicidal? So asking when you see red flags, that's okay. And when in doubt, if you feel like you can't deal with what the answer that comes out, then you refer. You refer to someone and do a warm handoff. Where you're like, I have this person, I'm concerned about them, and you lead them to the clinician that might be able to help them. Volunteer forces was another interesting one that I hadn't thought about. And it was that there are volunteer forces of firefighters and EMTs, and they don't have the same protections as those that are professional because it is a volunteer force. So how do you provide them with help that they need when they're not in a professional organization? That's another question to ponder because that's a whole population that you're not really looking at. Carrying a weapon. So many clinicians are wary of having someone carrying a gun when they're in session with them. One of the things that I was told is to work with the clinician, because taking away or telling a law enforcement officer, for example, no, you can't, makes them feel uncomfortable, and they might not, again, want to come in and seek help if there's a antagonistic response to them carrying. And assessing them for suicidality, etc., that would be a good first step. But again, that's an ethical consideration that many folks have had questions around, so I wanted to bring it up. And then finally, job safety analysis and psychological fit for duty. So these are, the departments have mental health resources to facilitate job safety analysis and psychological fit for duties when someone has had issues. However, the question is, do departments also provide mental health clinicians so that those folks can get help, or should that say separate from those departments, because that might create conflict of interest? Because again, as we go back to thinking about confidentiality, emergency responders don't necessarily want their mental health to be associated with department. So that would be another thing to consider. So that was a lot of slightly doom and gloom. So I want to say, are there strides being made? And the answer is yes. Nationwide, there are various organizations that are working to address mental health needs for emergency responders. I'd like to speak, because I know most about Responder Strong, I'd like to highlight what Responder Strong has done. So in March of 2018, Responder Strong with NMHIC sent out a survey to all the departments in Colorado to survey for, just to see what the mental health landscape was. And 55% responded to the survey. And what the findings were, that leaders are moving, thankfully, from that external crisis-directed services of let's do crisis debriefing and just leaving it at that, to day-to-day services and trainings to address mental health and emotional stresses of the job. So they're trying to build in mental wellness, not just talking about mental illness, but working in real time to address those issues. Second finding was that there are systemic barriers across branches for utilization and effectiveness of mental health supports. Many places have peer support groups. Many places have things here and there, but a lot of times they might not be integrated well enough. And there's also cultural barriers, stigma, talking about mental health. If you guys are familiar, the stigma in just the general population is high, so to think about how much the stigma there is in an emergency responder culture, much higher. So they found all of this out, and this was a good place to start of, okay, we have these issues, now what do we do? So in February 2019, yes, so earlier this month, we published our accomplishments in review, and they were successes. So what we, Responder Strong, with its over 500 members, created a work group of folks that created resiliency standards, mental health literacy standards, that would go into Colorado Community College system. So that now the new workforce of students, they start hearing about these things of what is resiliency? How do you self-care? How do you try and integrate the things that you see on the job within your life so that you're not going towards the red? The CU Anschutz START clinic just started. It is the Stress, Trauma, Adversity, Research, and Treatment Clinic, and it's in Building 500. My mentor, Laura McGladry, who's an awesome family and emergency nurse practitioner, she actually introduced me to the idea of stress injuries, along with some other clinicians, created this START clinic, and that's to address these issues within emergency responders, specifically for emergency responders. It's a safe place for them to be able to come get help. So that's one success. Responder Strong and NMHIC, along with other organizations, partnered up to do relationship and communication skills workshops. So one of the things that I talked about was family issues with emergency responders, from the crazy amounts of hours that they work to not being able to effectively communicate, like, you know, I saw something horrible, how do you talk about it? Or deal with it in your family dynamic. So there's a Center for Relationship Excellence in Denver, where they facilitate workshops that are specifically designed for emergency responders. I attended one with my partner, and it was pretty cool. I'm apparently like an otter, and she's some other type of animal, and like they tell you how to communicate with your different love languages, and it's not wooey, so it's very practical. It's like, how do you use this to become better humans? So those workshops are available. Then we're also working towards getting a clinician certification and endorsement program, CCEP. That is to address the issue of cultural competency. So clinicians, providers that have experience with working with emergency responders, they can get certified, and then emergency responders can look at resources and be like, okay, that person says that they do have experience working with my population, my kind of issues. I can go feel safe with them. So that's a certification program that's in the works. And then trauma retreats have been created. And there's more that are in the pipeline. And this is so that emergency responders have a safe place to go that's away outside of their work community, and they can start talking about these things and addressing these things. So those are some of the successes that are currently happening. Now, I'd like to ask everyone to take a look at this, check in with yourselves, see where you are. Oh, are you breathing? Oh, still? Now's the time to recognize that. If you're injured, there's still some time to walk it back. There's contact information for me, the National Mental Health Innovation Center. I did want to put, if you are struggling and you are an emergency responder, please text BADGE at your time to 741-741. There's also Colorado Crisis Services, and the number's up there if you're struggling or find yourself struggling later on. So hopefully with all of that, I've given you a little bit of taste for mental health issues amongst emergency responders. I hope that you found it interesting, and thank you so much for being here. Have a green day. Time for questions too, or if someone wants a stress ball, like, got plenty. Yes. No.
Oh, we got a mic right here.
Yeah, or the mic, that's fine.
I just wanted to thank you for coming and speaking about this issue. I was a firefighter and paramedic for 12 years. I worked in a very busy department. When you're approaching, I've had 2 colleagues during that period of time who committed suicide. There was a feeling of hopelessness around those situations in the tight-knit units that we had,
Right.
knowing that someone was spiraling out of control over something that we all dealt with like on a daily basis. When approaching EMS professionals or anybody in this field, it's important to realize that these are lifelong career decisions. So the general consensus is everybody figures out how to deal with it on their own. But it's an easy way to feel trapped. I mean, even I've been out of off the street now for 6 or 7 years, but even hearing these things still brings out emotion in me, because I think of it as a fun time in my life. I was young, but it's also very painful. And it's when I revisit it, I mean, I'm a faculty member here now, but it'll always be a part of me. And I just really applaud what you're doing. And I hope, I wish I could have came to something like this when I was 19 years old. Yeah, thank you.
You're welcome.
Any other questions before we end the session?
I had a question. I guess it involves EMS first responders, and that is in Colorado, we have a CPR directive statute which allows somebody to decline emergency services. Is there training specifically for EMS responders when they would arrive at a home called by somebody else and the patient is actually refusing their help? How do they handle that?
No, unfortunately, I don't know the answer to that question, but I can grab your contact information. Do you have the answer for it?
I've
Got the answer for it.
I've been in the ethics committee here for many years. There have been several cases we've had where EMTs feel it's not their job to interpret directives in the field and stabilize and bring them to the hospital. And I've never heard otherwise, actually. So the actual sanguine advice is, if you don't want to be resuscitated, don't call them until you're cold. That is your family. That's your family's issue, because that's their job. Is not to, oh, let me look at this. Is this properly filled out? That's really too much to ask, I think, of the MPs in the field.
Especially
I can give a little bit of perspective if you'd like. I'm an EM and EMS physician, fellowship trained through EMS, work here at university, have a couple of different medical director roles in the area. So refusals in general are going to be a system by system setup where the medical director will make decisions about whether they want to allow refusals to be done in the field. Now, are you speaking about cardiac arrests or just general refusals?
Most of the time, it's somebody with a chronic illness that's deteriorated and has decided not to accept further treatment. So are the EMS in touch with you live all the time?
It'll depend on the circumstance. So say in general, a patient, EMS is activated, they arrive on scene, and a patient refuses care. Our job is to assess, or EMS's job on scene is to assess whether they have capacity to refuse. Right? So that's, do they understand their condition? Do they understand the risks of not being treated or transported? Are they of sound mind? Are they not under the influence of drugs or other substances as far as you can tell clinically? If they meet, and are they not a child? If they meet those criteria, they can refuse care. Whether we agree with that or not, that may be a different situation. And generally speaking, they'll either have protocols, EMS will either have protocols that say they can refuse care if they meet those criteria, or if they're outside of that criteria, they'll contact online medical control for direction, meaning they'll contact an emergency physician or the medical director, run the case by them. The medical director might get on the phone and actually speak to the patient. That's my practice, to make sure that you're comfortable with that decision. But at the end of the day, if someone has capacity to make decisions, they're able to do that. It's not a competence evaluation, which is a legal evaluation, but it's a capacity evaluation.
How effective is it to have a family alert first responders in their area? Is that helpful to tell them in advance that they say have a child at home and the parents have signed a CPR directive? Do you know exactly where the EMTs will be coming from, or is that not a helpful bit of advice?
I don't mean to monopolize the conversation. We can speak offline. So for sort of advanced directives, that's again something that if someone has a valid advanced directive, most EMS systems will not initiate resuscitative efforts. Actually, I should say, if there's a valid legal document, they will not start resuscitative efforts. Period.
Thank you for answering.
Any other questions?
I don't know if this is completely relevant to this presentation, but if you know a friend or an acquaintance who is an EMT responder, and as a healthcare provider, you can say that they're under stress or they're going through something, but they're not talking to you directly about it, what would be the best ethical approach to telling them, hey, like, can we talk, or how do we start the conversation?
Yeah, no, that's a very good question. Does anyone in here want to address that before I dive in? No? Okay. It goes by case, I would say, and I don't know if I'm the most qualified to speak on this right now, but and correct me if I'm wrong, but I would start with just having that conversation of, I'm noticing these signs. Are you feeling suicidal? Are you thinking about it? And then also have at hand some resources such as clinically competent or culturally competent folks that you know would be able to connect with them and do a warm handoff as a friend. That would be my suggestion in the very basics.
Any other questions before we end the session?
So looking at the original military graded scheme for that stress response, there was a thing on the bottom for perceived responsibility for that individual. I was just kind of struck by green essentially was the responsibility of the platoon commander, sick was the provider, and everything else in between was the individual.
Yeah.
Did you guys think about updating that as you brought it into emergency responders? It felt a little, pull yourself out of your bootstraps as long as you're not yet a doctor's problem.
Right. We did, because we saw that it's not an individual's, like at that point you're not capable of, because you're hurting, right? So we changed it to change in worldview instead. As you go down the continuum, you're starting to look at things cynically, and you're not reaching out. But we take that away from like whose responsibility it is.
Any other questions?
Or requests for stress balls.
Thank you for
Thank you so
attending,
much.
and keep an eye out for our next event. Yeah, Ethics of Involuntary Psychiatric Holds in March. Thank you again.